how things go. So thanks to everyone. Welcome back. So this is our last presentation of the Integration Summit with the topic, can value-based payments help sustain integrated care? So again, please use the questions box throughout the presentation, and we can get to your questions at the end or follow up afterwards. And then use the chat for any comments. So I am now going to introduce my two colleagues. So David DiGiuseppe is the Vice President for Healthcare Economics at Community Health Plan of Washington. And Martha Abbey is a Senior Analyst. Martha Abbey is Senior Analyst in the Health Systems Innovation Department, also at CHPW. So they are going to be providing an overview of value-based payment. So David, you can kick us off.
Yes, good afternoon, everybody. Martha and I are happy to have the coveted last hour of the last day time slot. It's great of you to stick with us through this. So as you know, those of you on the provider side have been working closely with those of us on the MCO side, along with our HCA colleagues, to integrate care. And we've all been thinking about designing and or implementing value-based care. Martha is a recent transplant to Washington from the state of Minnesota, where behavioral health has been carved into Medicaid managed care since the beginning of time, if I remember that right, Martha. And Martha is going to give us an overview today of the intersection between integrated care and value-based care.
Well, thanks, David. I appreciate your introduction, and yeah, I first want to start with talking a little bit about some learning objectives. We're going to talk about program attributes that promote sustainability. We're going to review some behavioral health billing practices. And lastly, we're going to explore value-based payment arrangements and look into some outcome measures. There are three guiding frameworks that help shape my presentation of this literature review. I'm a relatively new employee here at CHPW, and I just recently finished my PhD program, and I am using some of the information that I did, and some of the research that I did to help facilitate this presentation. So some of the guiding frameworks that I want to talk about, first off, is that I have a framework that is based in social justice. My own experience as a clinical social work, engaged in policy, administrative, and clinical practice require me to talk about social justice whenever I talk about funding, primarily because funding determines so many other things, like access to care, the ways services are delivered, and then also who gets what kind of payment. Some of the things that I found in the state of Minnesota was that, you know, I was the first generation social worker that always had to bill for revenue. We had a very fee-for-service state, so we only got paid for when our clients showed up, which is often a little bit difficult with Medicaid and Medicare clients. I ended up working for a crisis program for years, and we had to transition from being a grant-based crisis program to billing for it, and we realized that nobody knew how to either market a service, or no one knew how to negotiate a rate for that crisis service. I then went to work for the state of Minnesota, and I created mental health Medicaid benefits, and I always tried to make sure that I was creating a benefit and payment that could let the agency be financially solvent when providing the service. But there's also that give and take of wanting to make sure that publicly funded services are, that the public is getting quality for their dollars. And lastly, during my dissertation process, I spent a lot of time looking at culturally specific clinics and all of the different rules that are set up within Medicaid systems that prioritize legacy institutions that have been around forever and usually have more of a white systemic infrastructure that makes it more difficult for culturally based communities of color to get access to the same resources. Now, this isn't just a Minnesota problem. This was talked about also in the HSA Equity Summit about a week or so ago. And it's really important that we think about all of these different social justice implications when we're talking about funding, that who has access to the resources, what do the resources promote, and also are we making sure that we're utilizing publicly funded dollars to get quality and effective care, especially for the most disenfranchised within our society. So these are some of the things that's the first framework that I want to talk about. The second framework is really looking at both integrated care, but also how we fund things determines what kind of service we get. And we're going to use integrated care as a way to describe that. So, as I'm sure that you've noticed in all of the different presentations, integrated care is needed and it works. So you can look at individuals with serious and persistent mental illness die 15 to 30 years earlier than their peers. There's higher rates of diabetes and respiratory disease. There's lower access to primary care resources. It also found that integrated care has positive effects on preventative and chronic disease care, and that co-located integrated care increases the utilization of preventative services and primary care visits. So these are all important things that integrated care can give us that help attend to our health disparities, but also are an innovative form of care management. Now, I also want to talk about the policy infrastructure that integrated care is embedded in, that it's within the Patient Protection and Affordable Care Act, that there are lots of federal and state grant funding for either like the Center for Medicaid and Medicare Innovation grants, also state grants. It's also a part of the HCA expectations. They have integrated funding here in the state now. And there's also a lot of state and local expertise and infrastructure with the AIM Center and with local policy experts. So with all of this different, like, we know it works, we know that it's important, we know that it's embedded in so many different policies, that leads us to question, why is funding it so complicated? If we all know that it works, if we all know that it's tiered in multiple different policies, it's so confusing that it's hard to bring these two systems together and make sure that we have a good basis of funding. SAMHSA has created this integrated care framework, which I'm sure most of you have already seen, that looks at coordinated, co-located, and integrated fully integrated care, and partly it's based on location of service delivery. That's whether or not you're in two different sites, how much collaboration there are between the sites, or if you're housed in one agency. And that also can be a factor of, like, are you employed by the same parent agency, or are you also have two different boards of directors, or two different employment systems. So these are some of the, so when programs are trying to figure out where they are on this continuum, they look at their location, clinical delivery, patient experience, practice organization, system, and business model. And I'm sure that you all have figured out kind of where you are on this continuum if you're providing integrated care, which kind of leads me to poll number 1, which should be available on the side. We'd like to just try to figure out, we've got 152 people on the line. We'd like to know a little bit more about what kind of care you provide, or if you're providing integrated care. So this integrated care framework, there's a bunch of different places on the model, and just because you're co-located doesn't mean that you meet all of the different attributes of that model. But we're here to talk about money. So we're going to go to the business model aspect. And as you can see from this, that separate funding to integrated funding, there are multiple different steps along the way. Can you guys still see my slides? Has something changed on my computer?
We could just see the poll results, and now it has a different background.
Okay.
Or the main slide.
Are we now good?
The framework. We're looking at the framework.
Framework. Okay, great. Sorry about that, folks. All right, technology. So coordinated, you have separate funding. There's minimal sharing of resources. Practitioner health and mental health, like health and mental health or behavioral health are billed separately. Co-located, you still usually have separate funding. They might share like office or facility charges, but it's still separate billing, separate systems. Integrated generally has a blending of funding, a blending of resources, and a sharing expenses and revenues. So as you can see, like how we fund as Medicaid funds, or how one receives funding, or better said, like how you receive funding determines what kind of service you can provide. So like if you're co-located, you can't really be fully integrated unless all of your billing systems are combined. So it's important to really think about the way things get funded determines how services are provided. Now that can be like if you think about fee for service, that if you only get access to funds by seeing someone in person, or I guess now in telehealth, that if someone no-shows on you, then you cannot receive payment for that service. So that dictates maybe who you keep as a client. Maybe that dictates how many no-shows a client is able to have. Or if you're in private practice, maybe that makes you enforce a fee if someone doesn't show up to their allotted appointment. So those are different ways that funding can help shape practice. Do we have access to the information on the polls?
Yes, it is being displayed currently.
Okay, what is the answer?
So we have 11% says we do not provide integrated care, 33% provide coordinated care, 11% provide co-located care, and 44% integrated care.
Oh, great. So we're a high amount of integrated care. So I'm sure that a lot of this is already common knowledge for most of you who are on the audience. That's great. So we've just talked a little bit about how funding can help, or funding kind of pushes into how services are developed. Resume. And now I'd like to talk a little bit about sustainability as my last framework. So sustainability is fundamental when you're implementing any program, and often sustainability plan is requested with grant applications, and it's always a struggle to try to figure out, like if one piece of funding ends, how does another begin? But it's also hard to there's different amounts of stability within funding. And we bring this up because a lot of integrated care begins through grant funding. There was a question that was asked at yesterday's session that wanted to talk about that there were startup costs that were funded through grant funding, and trying to figure out ongoing stable funding. That as programs look to exist after that funding ends, we need to develop ongoing financial systems that support that programming. And so that's really important. I'm utilizing the exploration, preparation, implementation, and sustainment framework for talking about sustainability. This is a very common evidence-based practice implementation framework in the literature, and also they have a partnership with SAMHSA for thinking about how to promote evidence-based practices within mental health and behavioral health settings. And they talk about the importance of sustainment to make sure that a program is embedded and has the capacity to survive. Some of the inner contexts that support sustainability are about your organization, the leadership, how much it's embedded in the culture, the critical mass within practice and practice support, and also fidelity monitoring. You know, like you start something, you need to make sure you have a data support system to make sure it keeps on going, and that you have supportive coaching to help make sure you're keeping the eye on the ball and you're getting all of the, you're being adherent to the model. And then also staffing. You know, you want to make sure that you have folks that are passionate about the service, and that they remember all of the different key components, and they're willing to engage, and that they're with you in providing the service. There are also outer contexts. So it's not just about what happens in the agency. There's also things that surround the agency that really promote or hinder sustainability. So you've got leadership with politics, like what does is this a part of legislation? Is this part of the Affordable Care Act? What happens to the Affordable Care Act? Is there a billing structure through Medicaid and Medicare? Are insurance companies willing to pay for the service? You had grants, and do you have ongoing grants? Do you have the ability to privately fundraise for the service? Do you have a foundation? All of these things are important aspects of the funding. And lastly, it's really important that you have external partnerships that help support this initiative and make sure that it's wanted by the community. So you want to maybe especially for evidence-based practices, you want to have academic research connections. You want to have any type of technical assistance to make sure that the model is going, and also that managed care and state folks like at HCA are invested in this program continuing to make sure that there are appropriate things in the future that align with your program. So we see that, it's not just if you have the right accountant to whether or not your program will succeed. Like if there's, is there state and federal leadership that backs your plan? Do they created appropriate funding mechanisms in order to promote the service? Are there enhanced rates for a particular model like DBT or integrated care? What are some of the outer context positive reinforcements that you're getting for providing the service? So some of the typical barriers to sustainability are financial, you know, not having secure funding streams, not having suitable resources, whether or not there's been worker turnover, people get trained and then they leave, or not having buy-in at all. Policy changes. So what happens with elections, with billing changes, when administration changes and they have a different initiative. And then lack of fidelity, like you don't have that ongoing support, and people are not adhering to the model. And finally, looking at policy and funding incongruence. So is there a desire for integrated care, but you have two different payment systems, or you have to have 2 to 3 different types of care plans? So in order to make sure that you're being adherent to the larger policy structure. So here we see that how we fund things and how policy leaders prioritize money and legislation determine who can and which programs will survive. And it's really important that you think about how all of these factors come together to make sure that you have a viable program in the long run. So considering the fact that we've talked about the framework, which, you know, social justice, looking at systemic issues that prioritize some providers and some types of care, the second is how we fund things determines what you can provide. And the third is how we fund things determines which programs will survive and which ones are sustainable in the long term. So now that we've talked about kind of the concepts that frame this literature review, let's talk about different options for paying for behavioral health and integrated care services. And also, why has funding been so difficult? So the first round that like back in the early 1990s or late 1980s, behavioral health, the transition from big hospitals to community-based care, and I'm sure you all lived through this. The transition from grant funding to insurance-based and Medicaid-based funding was bumpy, to say the least. That a lot of time in a lot of different states, in Minnesota, they formulated mental health based payments using the resource-based relative value scale, and created like a fee-for-service table. Now, the RBRVS, and if you're looking at the handouts, the formula is in the appendix. That the whole point of that was to come up with a formula and a numeric value that would appropriately compensate psychotherapists for their service. And so they tried to use this formula to make a system that would make behavioral health on the par and paid in a similar way as like surgery. But they realized that RBRVS, when they studied it, tends to overvalue procedures rather than actual cognitive work. So like with primary care, there's no ability, like it's harder to it's easier to say an x-ray was done than what kind of service happened during a 50-minute psychotherapy hour. So RBRVS tends to overvalue procedures, and it doesn't account for the severity of illness. So you get to pay the same amount whether or not someone is right out of the hospital and they're having acute psychotic symptoms, and whether or not they are this is their last session and they're on the path of recovery and they're doing really well. You get paid the same amount. It tends to equate time for cognitive work. So a 50-minute hour is not the same, like that. The amount of work that it took to prepare for the session is very different than it is for other things. And then there's also no component for quality. The last problem that generally gets people tied into it focuses on the economics of supply and demand. So while a lot of physicians can just see more patients, they can fit them in, fee for service, you only get paid for the people that you see, and it's really hard for a psychotherapist to book more than one client for the 50-minute period. So it makes it really hard for people to be fiscally solvent in this, or like it's possible, but it's really hard. And so with this, if we're using our framework, we think about this social justice. So it's accessible for all different types of providers to use, but it's also really difficult because if you choose to see the most complex individuals who are struggling with the most barriers to care, that it makes it hard for if you're only going to be paid for when people are able to come to your office. Two, if you're thinking about how you deliver it, it's very regimented to determining how care is being provided. So the money tends to determine the type of service in the sense of a 50-minute or like in the time unit mechanisms. And then lastly, it's hard for sustainability with the Medicaid population, just due to the fact that it is a struggle for people to get to services. Those studies were done in the late 80s, early 90s on the RBRVS system. A few years later, even though the majority of folks were using a fee-for-service or RBRVS for calculating their Medicaid or Medicare payment for mental health, they started doing studies on capitated or case rates. And there are studies done in Oregon, Colorado, and New York that focused on the capitated case rate. And they're said to allow for more innovation and and tended to combine fiscal incentives to contain cost. And that there was some evidence to support the capitated rates contained costs, but only if the clinic was large enough to be able to assume some sort of risk for for the flexibility and payment model. And it's also and then they also found that the outcome measurements and cost containment was generally yielded the same consistent results across all payment types. So there wasn't really a lot of evidence to support that capitated case rates were more promoted better outcomes for payment for clients. But there was definitely a lot of providers that preferred getting capitated case rates because they felt like that was easier to budget. It was made it so that they had more the ability to be more innovative in how they provided services, and that it's allowed them to be more in control of their own business strategies. So with this, if we're looking at the framework for social justice, this model works better with larger agencies and larger client bases, and it may need suitable reserves, which might hinder like a smaller community-based, culturally based provider. It also, the funding creates flexibility and allows for innovation. So that kind of opens up how payment drives the service. And lastly, that the sustainability, it continues to, like it really helps legacy institutions. It might provide more security for the agencies that participate in capitated case rates. And it allows for, again, more flexibility with the model. So it could promote more sustainability. So as I said before, that this is a literature review. It's we're just taking information that we're gaining from all the different studies that have been done over the past, 40 years regarding mental health payment. So as we had a big gap in literature between the case rates and the Washington's pay for performance study. There was a lot of energy behind looking at payment rate studies back in the 90s, and that diminished over time. And people had the way that they were paying. There wasn't a lot of energy in the literature. And then the Affordable Care Act happened. And so people started to have more of an energy to address payment changes, and they really wanted to get a little bit more knowledge on how we can pay for things differently. But as we mentioned before, that with the ACA, it was very much a push for integrated care. So now the behavioral health payment literature is really looking at integrated care rather than behavioral health alone. So if we're taking a look at the pay for performance study here in the state of Washington, it used the collaborative care model, the population-based approach, measurement-based care. There's supervision by a mental health professional and brief psychological therapies. The study talked about how there was augmenting funding up to 25% of the overall funding that was based on clinical quality measures. They also stated that it wasn't just that there was a pay for performance, that there was like money available at the end if they did these things. It was more that there was systematic data collection, feedback and training ongoing, and a substantial portion of the funding was tied to it. So it has to be a bigger, according to the study, it needed to be a bigger chunk rather than a smaller chunk in order to drive changes in behavior, but that the money alone wasn't sufficient. It was really some of the things that we talked about with sustainability in the inner context of, and the outer context, that there is this feedback loop of providing care and then getting information from data in order to provide more measurement-based care and and have checks and balances along the way. So, like like not all VBP studies have had the same results. The authors of these studies note that pairing financial incentives with chronic care quality improvement and capacity building efforts was key to the results. And it's important to note that the P4P increased the fidelity to the model in between the wide range of 9 to 30%. So that that's because of the support that they got in this process, that it wasn't just the clinics alone doing the model, but the support and the infrastructure that they received as attached to the VBP effort really did help improve depression, patient depression outcomes. And that's a key takeaway from this. So going back to our framework, we want to think about, you know, how social justice is implied for increasing access for patients and decreasing health disparities, but also that it might not increase provider diversity based on this model, but it might help out with attending to health disparities. And also, I think it depends on what we end up deciding we want our measures to be as far as social justice, and that might be an interesting way of bringing in social justice ideas to discussions about value-based care. Two, for payment driving service, it clearly indicates that having this kind of payment philosophy and the services that are attached to it did drive quality outcomes. And then lastly, sustainability, that money and fidelity are key ingredients to having sustainability. And so these studies suggest that using pay for performance might be a good way to increase the sustainability of a program. So, but not all of integrated care is done in pay for performance arrangements. As you can see from the slide, there are pros and cons to various types of payments that can directly influence how services are delivered. You know, fee for service makes sure that behavioral health has its own funding stream, which might create more autonomy for that department, but it also makes the program dependent on the 50-minute hour traditional outpatient modes of treatment. Bundled payments can support the team approach, but often they found that like in these studies that they're pulling from, the bundle doesn't include specific behavioral health services and funding streams, which might make the behavioral health person like a tangential or less authoritative person on the team, perhaps. And then lastly, global payments can facilitate seamless practice, but are also associated with a lot of risk, practice change, and transformation. So these are some of the things that they found in different payment models based on the integrated care literature. But beyond payment type, there are key ingredients for creating stable, secure, and financial infrastructure for integrated care, which takes active engagement from both the provider and the payer to achieve. So some of these key ingredients include correct coding for each service. Like that's something that I've worked hard at with when I'm creating benefits and like the funding for them, especially for the bundled service. It's really important to know what are all of the different core components for each service and what are the codes and what is the general payment for that code. Making sure that you have systematic data collection, whether it's through the EHR or in other different mechanisms. Negotiating adequate revenue streams with your payer or through the legislature. Electronic health record systems are important for people being able to share information about people, but then also for data collection. Attention to value-based quality metrics, know what you're looking for, what you're being graded on, but also what is key and helpful for your patients and your clients. And then lastly, monitoring the flow and quantity of patients for operational efficiency. So again, like if you have a fee-for-service process or or you want to make sure that you're maximizing the bundle, you need to know kind of how people are moving through the system and whether or not you have too much dead time for your providers, or you're not making sure that people are getting the service at the time that they need. So lastly, wanted to bring up the concepts of the buckets. So when you're thinking about creating your integrated care program and your funding matrix, it's important to think about, so you've got this grant funding bucket that maybe you had grant funding and you used it for startup funds. So it might have been for the training of the evidence-based practices, whatever training costs for integrated care as a whole. Maybe you wanted to change your facility so that your offices were closer together, or you had more patient rooms, and the development of EHR systems, or hiring people. So some of those are like one-time funds that hopefully are maybe a part of this grant bucket. And then you've got the ongoing covered services bucket. So things that you know are a part of the Medicaid and the Medicare plans, you know that an insurance company will pay for it. You've got an ongoing stream of services that you know are going to be covered, and you don't need a grant in order to do them. And you've looked through you've made this service grid, you've looked through all of the different core components, you know how you're going to get money from all the different service axes, and you've negotiated with your payers to make sure that you're maximizing all of those different avenues for insurance funding. And then you also need to be cognizant of the fact that there are some services that may be in the uncovered bucket, or things that may not have, that aren't covered within like the Medicaid benefit set. So you want to be thinking about, what are the resources I need in order to do data collection? What are the costs associated with program fidelity and ongoing training? What does it cost me to have the huddles and the consultation and the staff meeting time with all of those individuals, either on webcams or with bodies in the room? So how am I going to pay for these, and do my covered services and the charges that I get from the payers help me maintain the program and cover those costs? So it's important to kind of keep your eyes on all of those different things. So we've now gone through the payment literature systems. So I just want to check in. Have we had a second poll? Or are we about to?
We can launch the poll now.
Okay, great. David, do we have a bunch of questions that might be helpful to be answered before we move into value-based payments, or do you think that?
Martha, I haven't seen any questions. Colton, do you see any questions in the queue?
Currently, there are no questions, but the audience members, please feel free to utilize the questions functionality to enter some.
It shows that there are 140 people here, so if you have any questions, I could drone on about literature reviews. It's always a possibility.
Martha, if you don't mind, I wouldn't mind posing a question to the audience if folks are comfortable. You reviewed several types of payment arrangements. So if folks in the audience have any strong feelings about arrangements that have been successful and support what you're doing, or strong feelings about arrangements that have detracted for what you're trying to do, if you'd be willing to put those in the chat just so we can see that as we're going along, that would be great.
Yeah, that's a really good point, David, because my poll right now is trying to figure out what kind of payment systems they are using. But I think it's even better knowledge to find out what works, what's been helpful, and what hasn't been helpful. Good call out. So coming from that, we'll now move into a little bit of, I guess, do we have poll information, or should I?
We do have poll results. So it looks like roughly 60% of respondents selected fee-for-service billing, while 16% selected grant funding, and the remainder rates and per member per month.
Okay. So diversity of funding options as well. But
And it looks like we did have, in terms of the poll, that there are maybe some providers that are doing a combination of these, but our poll did not allow for that function.
Oh,
I think there are some combinations out there. And feel free to put those in the chat as well so we can capture those. So yeah, someone says grants and fee for service. So there's a combo going out there.
okay, thanks. All right, so the last portion of this exciting presentation goes to using value-based payments to enhance sustainability. So now that we've talked about the 3 buckets, where might value-based payments fit in? So we know that it helped the collaborative care site maintain fidelity and enhance care outcomes, but what is value-based payments and why are we talking about it? So we just did poll 2. So just like integrated care, value-based payments are embedded in health policy, in the ACA, in Washington state legislation, and in Medicare access and the CHIP program. So it's not something that is a whim. It's embedded in lots of different layers of health policy. And the core components of the Affordable Care Act of looking at increasing quality while decreasing costs and increasing access are all important components of that leads both the federal and the state governments to have an interest in value-based payments. So Washington State's value-based standard is that they use the Healthcare Payment Learning Action Network definition, and I tried to find like their official definition, and it's just this graphic. So in the state of Washington, we generally look at 2C and higher as being a part of the VBP standard. So pay for performance, alternative payment methods with shared savings or shared savings and downside risk, condition-specific population-based payments, and other integrated finance and delivery systems. So generally they have a cost and a quality component to them. And then there's a link there for the HCA measure set. So you can have a value-based payment system or arrangement with multiple different types of payments. So it could be with fee-for-service, bundled payments, total cost of care, quality gate and ladder utilization, that if you meet a minimum standard of quality, be able to gain benefit from whatever the arrangements. And then the ladder is when you increase your improvements, you can gain more. And then also global capitation. It's a myriad of payment options and a myriad of quality measures that would connect. And when you're making this arrangement, you need to determine and focus the program to target and to decrease both health and to increase health outcomes, or maybe decrease times going to the hospital or things like that. So some of the options for measures might be like to follow up on after hospitalization for a mental illness or patient experience with primary care, how providers use information to coordinate patient care, or things like comprehensive diabetes care. There's a, like on the HCA list, there's both health and behavioral health measures. And I think if you're doing an integrated care program, it would logically make sense that you would want to look at measures that might cross over into being physical health and behavioral health. We've got kind of like poll 3, which looks at a little bit of maybe thinking about what are the different health measures that you might want to look at if you're engaging in a value-based payments arrangement. Because it's important for us to think about, like, what are things that we think would mark good quality for our people that we're working for. Like, do we think that because of the health literature says that folks with diagnoses of schizophrenia and bipolar have more issues with diabetes? Like, do we want to make sure that we're looking at comprehensive diabetes care? So it's those types of things that we're coming up with a measure. We want to make sure that it matches the type of service that you're providing and that you need assistance in getting there. Because we'd like to point out, as talked about in the study, that value-based arrangements are a partnership. It's not just about the money. So as the P4P study notes, that technical assistance and the feedback loop and the extra set of eyes and a learning collaborative are important key ingredients that make a difference. So that if you are able to build a relationship with a payer and create value in that relationship, make sure that you're doing data provision analytics, getting help with that data infrastructure and health information that a payer might have, utilization and disease management, consultation and training, and partnering with other plans to ensure that administrative simplification. Like if you have an arrangement with one MCO, you could probably have a similar, I mean, like you want to make sure that you're measuring similar things with multiple people. And it's important to really think about how can this partnership help you create an infrastructure and a system for managing the program that you have and making sure that it's an added value for the program, as well as just being a part of a funding mechanism. All right, so some results?
Yes, we have some results. So it looks like roughly 60% of respondents selected mental health and SUD penetration rates, while we have a tie for 14% comprehensive diabetes care measures and medication adherence.
Thanks. All right, so let's go back. So VBP arrangements can also helpful to know that you're facilitating more knowledge about the other arm of healthcare. VBP arrangements have opportunities for funding flexibilities and stability and getting alignment and payer approaches regarding quality goals and reporting, being able to partner across the continuum of care, and facilitating data sharing and understanding. But they also come with challenges. Like it's really hard if you have limited cash reserves to invest in a newer arrangement. Pivoting and going in a different way is can be stressful. That if you have difficulty with data analytics and data infrastructure, sometimes it's hard to then want to go into something that is more data centric. And then it's also like trying to figure out, like if you are partnering with another agency, so if you're a clinic and you're doing co-located care and you've got different employers, now you're building a relationship with the payer, the primary care, and with the behavioral health, and trying to figure out how much risk you all have, or like how much shared savings, or how to negotiate all those other things requires a lot of in-depth conversations and relationship building. And it's also difficult to manage risk, especially with the burden of poverty and illness within a safety net. So now, after all of this, we're 50 minutes in. The question is, can value-based payments help sustain integrated care? Like, will it help move behavioral health systems towards socially just payment? How will it determine the type of services providers have to provide? And will it facilitate sustainability? So if we go back to the sustainability framework, if you're thinking about the outer context of funding and facilitating partnerships, VBP really has that opportunity. It helps facilitate most of the inner and outer context. It also allows for variability and innovation that will give providers the flexibility to provide the type of care that they want or need to. And it also can help with the inner context issues of making sure that there's fidelity, or with getting information on population health and measurement-based care delivery systems, and embedding quality into the culture of an organization. So all of these different things can really help increase fidelity, get more technical assistance and supportive coaching. It creates a feedback loop for performance. All of those different things can really help with quality of care, and also with integrated healthcare delivery services. So that's the slideshow portion.
So Martha, that was a fantastic overview. I can't imagine how long it took to read 40 years worth of BBP research, but you did an amazing job. Thank you. Stephanie, it looks like you're seeing some questions coming through that I may not be seeing. Did you want to?
Yeah, we do have a number of questions, and I think a lot of these will be done in follow-up. But one thing, there was a questions about measures, and like depression, remission, and response is a Washington going to be a common measure coming up. But I wonder if you can talk just in general about the common measures, and how providers should engage with payers in terms of what measures they might want to be incorporating into their discussions or arrangements.
Sorry, I missed that. I'm trying to figure out how to be able to see you.
You can.
Audience view.
Your videos might be hidden. I'm not sure.
Okay. Okay, so I'm going to stop sharing the screen. So, okay, sorry. David, do you have?
Yeah, I think at the highest level, we on the MCO side want to do, look to standard measures. So the core measure set's a great place to start. The VBP measures that the healthcare authority uses to assess MCO performance, and that's where the mental health penetration and the SUD penetration come into play. So those are both great places to start. And then, we look to work collaboratively. I mean, I think all the MCOs look to work collaboratively with you folks on the provider side in terms of, what are measures that would work for you across all arrangements that you have in place to make it as easy as possible.
Yeah, I think there were a lot of questions about policy on the policy side, so legislation, and this might be a little bit of a can of worms, but in terms of Washington and how we operate, are there the rulings around the ACA, what options are available kind of Washington state that are separate from the ACA, or that might still exist if there are challenges to that?
Well, my understanding, and I'm not necessarily a Washington state legislative expert by any means, but on an HCA WABI presentation, they talked about how a good chunk of the ACA infrastructure was put into Washington state legislation. So there's been some infrastructure created within Washington that is not wholly dependent on the Affordable Care Act to promote things like integrated care. But I do not have, I can tell you a lot about the academic literature. I do not have WACs and RCWs memorized.
Yeah, Steffi, I think our HCA colleagues could probably speak to this better than we could. My understanding is that if there were a challenge to the Affordable Care Act, and if there was something huge like a rescission of the Affordable Care Act, it's the expansion side of the Medicaid program that would be at risk in the short term. And I suspect that integrated care would remain for the lines of business in Medicaid that have existed prior to the Affordable Care Act. And then, depending on how things go in the congressional election, presidential election, I'm assuming that there'd be some action to reinstate the pieces of the Affordable Care Act that would make it past the Supreme Court.
Great. There were some questions about specific billing codes around the health and behavior codes and the collaborative care codes for Medicaid and whether MCOs cover those.
I think that that's a MCO specific question. Wouldn't that?
Yeah, I think so. I mean, generally, there are a list of services that we all are required to cover. I'm not personally familiar offhand with how that overlaps specifically with collaborative care and PCBH, but I think that's something that we could follow up, or each MCO, I'm sure, would be happy to follow up with providers on that question.
And we're about a couple minutes out, but I do want to recognize someone asked about SDOH and how to, the social determinants of health, and how do providers get access to, know about what resources are out there to improve equity. So I think that's something that we can include in follow-up, maybe if we have some resources. I would think the managed care organizations also have access to resources to support our members in those aspects as well.
Yes.
Great. So Martha, I don't know if you can get the slide deck up again. We wanted to highlight, so obviously this is just one talk around value-based payment, but there is an upcoming summit by the BRE Collaborative around value-based payment coming up next week, and you can also access that. Maybe it didn't make it to the slide deck.
It didn't.
Access that perhaps in the handout if it is there. Otherwise, you can Google the BRE Collaborative and find out about the summit that they have upcoming and really have more information around value-based payment. And then, so that is the conclusion of our summit. So we want to thank everyone for joining the 5 managed care organizations in this summit and learning more about the different aspects of integrated care, and just informing yourselves around the different strategies for integrated care as you go through this journey. Also, a reminder that we do have an evaluation form that will be coming out through GoToWebinar. So that is on its way, and we definitely want to hear your feedback. We will also be posting the recordings and all the handouts and other resources that come up in terms of the questions that have been posed on the Joint MCO website on the Association for Washington Associated Plans. So we will be sending a message out when those resources are posted, but so those can be accessed in the future. So again, thank you everyone for joining us and for all that you do for the Medicaid members within our state, and delivering that care that's definitely needed for our community members across the state. So with that, have a good night. And feel free, if you have any questions, reach out to your managed care organizations. We're happy to engage you in these discussions as well.
Thank you.
Thank you, Stephanie. It went great.